I made some changes to my best case of the year to my best save of the year, if you don't mind. All right, I have no disclosures. Patient is a 62-year-old man presented with chest pain at outside hospital. He has a history of hypertension, diabetes, COPD. He's in home O2, 2 to 4 liters, CKD with creatinine 1.8, active smoker. In terms of his PAD disease, he has severe PAD with FIM and FIM-POP bypass in 2016. When he presented to the outside hospital, he had a chronic limb ischemia and had a thrombosed bypass to his leg. So what they did thrombectomy there, and on post-op day 4, he developed chest pressure. This is EKG on when he had chest pain. As you see, there's some dynamic, subtle ST changes, but troponin came back of 3.4. Angiogram done radially at outside hospital. Unfortunately, I don't have too many images. This is taken from the CD. As illustrated here, you see calcified before the contrast filled the RCA. There's calcified RCA with tight lesion in the mid-segment in the 80% range. In terms of left main, it's again trifurcated into RCA, it's into a circ, ramus intermedius, and LAD. LAD is subtotaled and severely calcified, and there is trifurcation lesion at the distal left main. So the patient was transferred to us for further management, and we had a surgery heart team approach. Going over the comorbidities, he has 3 vessel disease with left main. He has severe PAD, and the vascular surgeon said, don't touch the legs. Has severe COPD, FEV1 came back at 20. LV ejection fraction on echo was 45%, EDP 22, STS score 10, syntax score 33. And the surgeon said, with these comorbidities, we cannot take him for surgery. And he was referred for high-risk PCI. Just planning for the procedure, giving his hemodynamics, I will show you before we did it, they didn't do right heart cath in outside hospital, and left main intervention probably going to require mechanical support. Severe PAD, probably going to go radial first for everything, which can be challenging, and severe PAD, alternative access for large bore access and large bore sheath, given the legs are really not in good shape. Calcified left main, need atherectomy, and keeping in mind he has creatinine is 1.8. So in terms of large bore, I mean, we have 2 options. This is not the patient images, fortunately, but again, this doesn't look even better. You have 2 options. Either we go transcaval or to go transaxillary. But we have some pros and cons with transcaval. It has accommodate large bore. It can bypass the calcification, but technically challenging and requires CT planning, which is another contrast load to the patient. So therefore, probably not going to be in his favor. In terms of axillary, it has a steep learning curve, but it is considered kind of faster, require less planning in terms of CT, and can be used for emergent procedure. The cons of it is it's a 6 millimeter vessel, and if it is does not take 5 liters ampulla, which is we don't need in this case. So the anatomy is you divide axillary to 1, 2, and 3 segments, and our aim was to aim for that segment between the axillary artery between the 2nd and 3rd segment, which is just lateral to teres minor. This is again the landmarks. It's favorable in this area to stick the axillary artery. It's because it's compressible in case you fail and there's bleeding. It's far from the brachial plexus, so neuropathy is less and low risk for pneumothorax. So back to the patient, going through the left brachial vein, we did the right heart cath showing index of 2.4, output of 4.7. RV filling pressure were not bad, but PA pressure were 45 and 28 and EDP 22. So again, going through the radial axis, we doing an angiogram of 6 French was gained, and after that we did a Rabi that did an angiogram just to confirm the appropriate the vessels. As you see, there's some diffuse disease, but nothing flow limiting. Again, after getting the access, we advanced a stiff wire, and over the stiff wire, advanced a large sheath, which is a 14 French sheath and pillar sheath. And after that, the pillar wire go over through the MP to the LV and advance the ampilla. After gaining positioning, this is the angiogram, and our strategy is to go, as everybody alluded earlier, to be simple. You have a very calcified left main and also subtotal LAD, so provisional was our strategy. And if we require some kissing balloon at the end with we'll do it at the end. So this is the left main. We did several ballooning for the left main, but did not change. So we exchanged over a microcatheter from a Pro Water to Viper wire, and we advanced a coronary CSI to 1.25 millimeter, and we did a couple of passes. Atherectomy was done, and this was the following image. I'll let it loop for a little bit. So you see there's a big mushroom coming up from the left main. So obviously this is...
So hold off there, Shadi, for a second.
Yeah.
So let's talk about this. First, the approach to a distal left main bifurcation. I heard Shadi say a provisional approach rather than say a DK crush, which I think at this point the data for the distal left main really is in favor of that approach. So unless the side branch has essentially no disease, I think DK crush would be the optimal approach. Having said that, there's a ramus here as well, so that further confounds that issue. So first, let me ask that question of the panel. Manish, how do you approach it?
Yeah, I mean, I think, again, I haven't seen an LAO caudal view and don't really have a good assessment of what the origin of the circ looks like. But, you know, clearly, I mean, here this is sort of a challenging case with a lot of downstream disease as well and severe calcification. So, I mean, if you're going to use a two-stent strategy, there are many. DK crush is probably the more data-driven two-stent strategy. But again, if you're going to try to just piece this together and quickly get the left main done, a provisional approach is okay if the origin of your circ is not severely diseased. Otherwise, it's not the optimal therapy for this particular patient.
Dmitriy? Yeah, no, I absolutely agree. I think here, especially since we haven't seen some of the caudal views and don't have a good idea about the origin of the circ, I think imaging would be extremely helpful. I think imaging into the LAD and circumflex and identifying how much calcium or how much disease you have at each ostia can help you to make that decision whether you're going to go DK crush or you're going to do one stent technique.
So I think that's an important distal left main differentiator. If we know the side branch ostium is simple, not severely calcified, not severely diseased, then a provisional works great, and imaging can be very, very valuable. So looking at this left main, as bad as that looks, if I'm going to have a left main perforation, this is one I actually like. And so again, maybe Gautam, you can tackle that, or other people on the panel. What's your thought about this particular perforation? Why do you think it happened, and what's the approach you would take at this moment?
So, Chadi and Shami, I think this is a guide perforation. This is not an atherectomy perforation. Looking at the location, if you look at that tip of the guide, it is right into where that perforation happened. I mean, it's hard to be 100% sure, but this looks like a guide perforation. In any case, you know, it's a perforation. I think the most important thing is to, in this case, tamponading this is probably not going to be straightforward. But I think first thing would be to try and get a balloon in there, get a pericardiocentesis tray ready, and start finding out where your covered stents are. Because that is a fairly big perforation. I'm not sure it is going to seal with just balloon tamponade. Thoughts, Dale?
Yeah, I agree. And, you know, it's really helpful that we have hemodynamic support here, because without that, there's just no coming back. But yes, a large balloon, hopefully you have a large guide, so you need a large balloon to quickly occlude flow. You'll be occluding flow down the entire left coronary tree, but that's where the hemodynamic support here helps you, at least until you can then assemble additional tools to help correct this.
And I think radial first is generally a good idea, but when you know that you're going to be tackling a left main, especially planning DK crush, even though you can get away with 6 French, you do need very frequently, including this case, a larger guide, and so planning in advance would be key.
I think it's also important to highlight maybe a little bit more about your atherectomy. If you go too fast with orbital atherectomy, or if you go on the high speed, you're more prone to perforation. Can you talk a little bit about what speeds you used?
Yeah, so I think the technical aspects are important, and maybe Chadi can comment on that a little bit. The other part, as I'm noting where this perforation is headed, it's hard to know if it's really into the pericardial space. It almost looks like it's somehow ending up in a different vascular bed. Too fast to sort that out quickly. And guide catheter tip dissections certainly could look like that, and potentially perforations could as well. So you got to get rapid control of this.
So the speed was at 120, but the one of the issue that happened, this happened in July, is we turned off the CSI in the guide. So before going out, I think this is one of the, going in retrospect, thinking about it, so the CSI just jumped out as like a bullet and basically kind of perfed the left main. But again, we think it's due to CSI because the engagement was fine, the first picture was okay, but I think it's mainly CSI driven. Just to
So rather than saying CSI driven, I would say probably atherectomy driven, and it occurs with both devices,
Yes,
which is,
exactly.
it can have a lot of stored tension. So you want to make sure you don't activate either of these two, rotational atherectomy or orbital atherectomy, in your guide catheter. You got to get out of the guide catheter, preferably a centimeter plus proximal to the lesion that you're trying to treat, and just a gentle tap, and you'll see that it'll jump forward about that centimeter or whatever the stored tension is. If you activate in the guide catheter and you don't relieve that stored tension, when it comes out, it can come out, and if it's up against a wall, it can cause that damage.
So going forward with the case, the left main was worked quickly with another pro water, and then balloon 30 by 20 was inflated. As you see, there's still a leak coming out. It's probably from LS score from 3 down to on the right side to 2, but still there is pure flow coming out into the left main. This is to confirm that this is going to the pericardium. So during that time, as you see, it's going to be a panic moment where anesthesia was called, surgery was called, patient fully anticoagulated, ACT is 256 because of the impella for sure. We cannot reverse him at this point. And the pericardiocentesis kit was brought to the bedside quickly. So again, this is the point we mentioned, echo confirmed at the bedside quickly, but again, we have enough angiographic evidence, and the fluid was wide open, and the impella was at full power. Again, after inflation for higher pressure, continue to see some mildly sealed perforation, but again, we need an ultimate therapy for this perforation. So graft master were brought to the room. It's a 4 by 16. After multiple positioning, without, as we know, we have some circ coming out and ramus without compromising the branches. It was inflated at 16 and then brought proximally and inflated at 18 ATMs for 32 seconds. And again, we're glad we have hemodynamic support, otherwise that will be unfeasible. This is kind of the sealed, after finishing the sealed graft master, seeing there's no perforation, and distally there is the LAD, again showing his disease, but there is no osteal compromise to the circ, ramus, or the LAD. This is final angiogram because patient was left, he was intubated. This is final angiogram just to make sure distal to the access point there is perfusion. Patient admitted to the CCU, low dose levo-fed, and we did autotransfusion on the bedside. So what we did is we got a large 8 French sheet into the femoral vein, and we start doing autotransfusion with 60 cc syringe with a 3-way valve by sucking blood from the pericardium, putting it back to the venous. So the hemoglobin was probably when he came to the cath lab was 11.2, and when he left was 9.7 on the CCU. Fusion, again, was not detected on serial echocardiogram, and this is after 24 hours, was a small effusion, and the impella was removed the next day. So in terms of take-home messages, as most of us has already alluded to, is alternative access for large bore is for severe PAD this is one of the options. In this case, for osteal calcified lesion is passing and treating probably on the way back. Probably it's more safer, but Dr. Parikh and Dr. Mahmud mentioned is probably advancing distal by 1 centimeter and then turning on low speed and going slowly, and target for treating that lesion going backward more than going forward. Radial first, I mean, again, we finished the case with a radial axis. There was, despite these issues, and the CTO card is very important. So to make sure you have a precardiocentesis kit and you have a cover stent that is not expired. Thank you so much.
So, Chadi, did you end up imaging this at the end after you got control? Just to make sure that everything was
yeah.
expanded?
Sorry, I mentioned to do it, but I couldn't pull the images from the IVUS machine, but it was well opposed and there was no kind of leaking out of the graft master.
And of course, there's a ton of LAD disease beyond that. That's going to be for another day, hopefully, if,
Yeah.
if,
So
if
this
and when he
happened in-
recovers and needs it.
Exactly. So this has happened earlier this month, early July.
Okay, great.
Just a quick question for the panel. I know that we, prefer atherectomy when we can do it for calcified lesions, but for an osteo lesion like this, how about the use of just high-pressure cutting balloons, high-pressure non-compliant balloons to reduce this risk we've seen?
Well, this was really a distal left main disease, and so and not an osteo per se. And I would say if you have circumferential or 270-degree arc of calcification or greater, cutting balloon, if anything, increases your risk of vessel perforation because the calcified area does not yield, so the only area that can yield is the non-calcified. So I would say if you use imaging and you've demonstrated severe calcification, then don't see if you can get away with it. Treat with atherectomy up front. And this particular case was more of a technical, I would not blame atherectomy. I think these things happen when you don't pay attention to some of the technical details. The other point I should make is if this perforation involves the distal left main and you have to put a covered stent from the left main into the LAD, let's say, and you think you're potentially compromising the circ, you can use a Confianza Pro 12 and actually go through the covered stent. You know where the circ is, and you can go in that direction and open that up, and we've done that successfully in the past. So the fine point there is you want to make sure, as long as the perforation wasn't right at that point of where the osteal circ is, you can still preserve your circ and use a covered stent even for a distal left main perf.